Hello and welcome to this video presentation investigating into the specialised area of art therapy practice within personality disorders in inpatient psychiatric units. Specialised art therapy practice can be defined as predominantly non-verbal intervention, characterised by interpersonal complexity and heightened levels of risk. The video essay will inform, educate and persuade. It will include relevant art therapy theory to underpin the argument and the evidence and understanding of safe, effective practice in the specialised field. The video will be structured around 4 key themes. These themes are navigating psychological and interpersonal challenges, tailoring and co-producing art therapy for challenging behaviours, the function of art making, and managing risk for non-verbal interventions. So, what is a personality disorder? A personality disorder can be defined as a condition that affects how you think, feel, behave, or relate to other people. There are different types of personality disorders with different symptoms. For instance, impaired nonverbal communication styles, disturbed ways of thinking, impulsive behaviours, and problems controlling their emotions. To achieve safe and effective practice, you must make sure you understand the condition of the service user you are working with. For example, with personality disorders, often the service user may have disturbed ways of thinking. It would be important to explore this within supervision, as well as having training of how to tailor the intervention to work with these risky behaviours that benefits the service user, as well as knowing what as a student you may not be able to handle or have appropriate training in yet to keep yourself and the service user safe. The way personality disorders was diagnosed changed. This was because it was felt that there was unnecessary complexity, inconsistencies with data, and minimal consideration of severity. The change was in hope of leading to greater understanding and care from a more evidence-based model. The 3 Ps is used to diagnose if an individual may have a personality disorder. Those with personality disorders may have struggles within their interpersonal relationships. Within the intervention, the therapist can work in partnership with the service user to co-produce effective art therapy interventions adapting to their differing needs and communication styles, building trust within body language. The term personality disorder has been criticised due to an unclear cutoff between personalities, labels that feel stigmatizing, and those diagnosed with the same personality disorder have differing problems. Personality disorders can be categorized into clusters, such as Cluster C, avoidant, dependent, and obsessive-compulsive. An acute inpatient ward is for when the person requires assistance with coping skills that promote self-management. It has a collaborative approach with individual care interventions and risk assessments. Those admitted to the wards are often unable to manage their risky behaviours towards themselves and others. To keep the ward staff safe and service users safe, risks are assessed daily through headcounts, checking for sharps, and staff wearing alarms. To tailor to the service user's need, regular visits from referrers, MDT, meetings, and communication with care coordinators is vital in monitoring the progress or lack thereof, in which case deciding what changes need to be made to benefit individuals. This is also achieved through formulations which explore each individual's needs, values, identity, and meaningful activities tailored to each individual to support them in identifying and overcoming any barriers they may be facing. You will either be detained under the Mental Health Act or be a voluntary patient. Individualized formulations explore your values, identity, and meaningful activities. Within the unit, you will be aided in overcoming barriers through 24-hour help to help improve resilience and quality of life. When working within a specialised area, it means that you have to undergo training to support a particular need of people and know how to effectively provide interventions for them that have a coherent and safe approach. NICE guidelines states that you have to be trained to diagnose borderline personality disorder, assess risk, need, and provide treatment and management, as well as regular supervision and staff to support to maintain safe practice, as well as building trust, open, engaging, non-judgmental, consistent and reliable relationships that help towards recovery. Art therapy actively benefits personality disorder service users by supporting their difficulties in communication and building interpersonal relationships. The art materials, such as clay, allow them to explore and express their thoughts and feelings to better understand and work through them, as well as allowing them to feel grounded and building on their confidence and self-esteem. Working in a team when it is running effectively promotes safe practice, as it ensures service users' wishes and goals are adhered to. This allows for a more co-productive approach by allowing them to have more of an informed decision about their care. When the team doesn't work effectively, this can limit practice by promoting disorganization, not feeling listened to, burnout, poor communication, not clear guidelines, lack of trust, lack of support, and poor decision making. The service user may then not trust the MDT, especially those with personality disorders who already have troubles with engagement and ambivalence. Discrimination in personality disorders can influence health and impact practice through stigmas such as words like untreatable, which may result in clinicians avoiding supporting those with a personality disorder diagnosis. This can contribute to the individual's negative self-image and self-harm risks. Research shows that personality disorders are the most stigmatized conditions in mental health due to professionals' negative attitudes towards them. This can impact practice by lowering empathy, reduce availability of services, and the quality. 80 references were stated of words used such as unmanageable and impossible. It is believed by some that life experience contribute to the personality difficulties they express. Discrimination can influence health as it has been linked to depression, trauma, anxiety, and low self-esteem. This could be due to them feeling their voices are not being heard, as well as humiliation and powerlessness, which can all lead to ill mental health and well-being. Discrimination can cause limits to practice by staff avoiding working with patients and them not receiving the best care from stigmatizing views. Disadvantages in early life such as deprivation can influence physical health. For instance, those in the lowest income households have a higher prevalence for psychotic disorders such as personality disorder. Good equality and diversity practices ensure that the services are accessible and fair to all and that everyone is treated with respect and dignity. Other disadvantages that can impact health are ACEs. Adverse childhood experiences. These are stressful events including domestic violence that can cause toxic stress. This can change brain development and affect how the body responds to stress in later life. This can also lead to insecure and disorganized attachment styles within the human development, which can lead to difficulties in interpersonal relationships in the future. This can also result in an increased risk of conditions such as personality disorders. Within the human development, intergenerational trauma and pre-birth trauma can influence learned behaviours and development of fetal brain systems that can result in psychiatric disorders such as personality disorders. Brain development of personality comes from a complex neural construct shaped by genetics and early developmental experiences that influence the structure and function of the brain. The frontal lobes are considered our behaviour and emotional control centre and are home to our personality. The development and maturation of the prefrontal cortex occurs primarily during adolescence and is fully accomplished at the age of 25. Personality disorder can be developed from an unstable or chaotic family life, such as living with a parent who is an alcoholic, little or no support from your caregiver, a lack of support or bad experiences during school such as bullying, poverty or discrimination, or some form of dislocation such as migration. Personality disorders can also be developed from intergenerational trauma passed down through genes and learned behaviours, as well as the stress hormone cortisol passed through the umbilical cord during pregnancy, influencing fetal development. Research supports a strong relationship between childhood maltreatment and internalized psychopathology, e.g., anxiety and depression. Adaptive traits can mediate the effect of childhood trauma history on internalizing symptoms in adult individuals. Behavioral genetics attribute 30 to 50% of the variance in personality trait expression to genetic factors. Research has attempted to account for the remaining 50 to 70 of variance through a range of putative, biological, and developmental contributors, including perinatal attachment, emotional regulation, and self-image. Culture and diversity impact practice by people having differing views, treatment-seeking patterns, and issues of racism and discrimination. Because of this, to maintain safe practice, we have to be aware of our own unconscious bias, beliefs, assumptions, and attitudes, and to be culturally aware of other people's social graces and intersectionalities. To achieve the most effective working alliance, misunderstanding, ignorance, and preconceptions in other cultures can be a limit to practice. It is important to always be culturally aware and understanding of others. Within personality disorders, often they display challenging behaviours such as disassociation, which is avoidance and interpersonal distance. This is a limit to practice as it can create issues in creating and maintaining healthy and positive professional or personal relationships. Having positive relationships is integral to positive well-being and self-confidence. This could also cause other challenges such as ambivalence in believing diagnosis or about their goals, or other states such as hostility, suspicion, and shame. To manage this and adapt to practice to the needs of the service user, we must put them first, co-produce the work and co-design of the intervention, follow their lived experience, attune and mirror to them through ostensive communication, keep up to date with continued professional development, and report any risk and safeguarding concern. To adapt to disengaging personality disorder service users, you can build trust through listening, responding to their feedback, setting expectations and goals with them, understanding their personality type, and meeting them where they are at. Brainstorm with them what and how would boost their engagement, and praise and recognize the engagement and autonomy they are able to bring to their intervention. Challenges with nonverbal personality disorder service users could also be lack of congruence, rapport, feedback, clarity, and authenticity that may lead to a limit to achieving an effective intervention. To adapt to this, you can develop nonverbal communication styles such as facial expression, body movement, gestures, and eye contact to connect to and understand the personality disorder service user. To tailor interventions for personality disorders, staff must be experts in managing conflict, comply with boundaried relationships, and have regular supervision to keep themselves and service users safe. The challenges professionals can face from working with personality disorders could be exhaustion and unpredictability, which could limit practice by having difficulties connecting and feeling fear at work, which would be transferred to service users. It is important to understand your limits of practice as a student so that you are keeping yourself and others safe. The guideline states that you should only treat service users that you are competent in working with through education, training, and experience, and within your scope of practice, as well as keeping up to date with research evidence defining the best clinical approach. Problem-solving skills can be used during assessment and formulation with a personality disorder service user for making sure the treatment is effective. This is because it allows the therapist and service user to co-productively identify any factors that may make the therapy not suitable at this time, as well as hearing the service user's expectations and what can be achieved together. This means it is adapting to their needs by focusing on their difficulties and strengths, whilst being recovery focused. This can be focusing on past, current problems, also allowing the service user to co-design how their intervention will be delivered, allows for power sharing and working with instead of to. This puts the service user first through focusing on their lived experiences and making sure the intervention is adapted to their differing needs. To adapt to the differing needs of personality disorders, formulations can be co-produced using the 5 Ps. For example, in predisposing factors such as early childhood experiences in trauma, neglect, and deprivation that increase vulnerability in adult life and affect an adult's personality. Personality disorder service users can co-produce with therapists by being involved in their own care. For example, the service user having a say in their care plans and being able to attend meetings with MDT, as well as allowing them to give feedback on the service. Within the guidelines, it states that the therapist should put the views and interests of the service user first. Research and reasoning can be used to ensure a coherent approach to practice by being informed by the service user's lived experience. This gives them more control over how their support and needs are met by power sharing and being service user led, by putting the service user first and at the centre to work alongside them, and to be adaptable, for example sitting on the floor if that is what the service user needs, as well as taking into account the differing cultural and diversity needs and preferences that may impact practice, for instance prayer times. Other ways to adapt to differing needs for personality disorders is to consider communication styles, such as ostensive communication. This is because personality disorders make communication and relationships challenging, as they are likely to experience impairments in expressing and communicating their messages verbally. Ostensive communication is use of tone of speech, eye contact, and body language. It allows the therapist to attune and regulate to the service users better. Additionally, the art provides a non-verbal avenue for self-expression. They can explore their thoughts and emotions and experiences in a tangible way. It was once thought that people with personality disorders were unlikely to recover. More recent research following up with people with borderline and antisocial personality disorder suggests that there is a substantial amount of positive change over time. The change occurs particularly in the area of impulsive behavior and emotional instability. This change is likely due to maturation. Over time, people become more able to predict the consequences of their actions, learn how to regulate their emotions, and become more accepting of them. It is thought that many people with borderline personality disorder have something wrong with the neurotransmitters in their brain, particularly serotonin. Neurotransmitters are messenger chemicals used by your brain to transmit signals between brain cells. The DSM-5-TR indicates that a personality disorder diagnosis in a child is unusual, but that a doctor can give one if maladaptive personality traits are present for at least a year and are persistent, pervasive, and unrelated to a particular development stage or another mental health condition. The DSM-5-TR notes that, for example, the children often display traits of personality disorders that naturally decline as they near early adulthood. These traits, like narcissism, are part of a developmental learning. People living with borderline personality disorder are at an elevated risk of premature death. A study that followed 290 people across a quarter century, evaluating every 2 years, found a significantly higher risk of suicide in the borderline personality group. But 14% of people with borderline personality had early deaths from other causes too, while the rate was just 5.5% in the comparison group. A precise life expectancy depends on many factors, including other health conditions like obesity or alcohol and drug misuse. Of all the people admitted to hospital, 9.7% had a personality disorder diagnosis. The admission rate for personality disorder has increased each year. Compared with white subjects, personality disorder was significantly less prevalent among Black and other minority ethnic BAME groups. World Health Organization WHO study prevalence of personality disorders 6 to 8.6% in Bangalore, 24% in the UK at the primary care level, and 8% at the secondary care level. Psychiatric outpatient prevalence rates varied between 40 and 92% in Europe, 45 to 51% in the USA, and 60% in Pakistan. Prevalence of personality disorder diagnosis in adult, child, and adolescent, old age, and forensic units was adults 11%, child and adolescent 8%, forensic 20%, old age 2%. If you have a close family member who is dealing with borderline personality disorder, you may be at risk too. One strong predictor of the disorder is family history. Having a first-degree relative, parent, sibling, or child with borderline personality disorder puts you at a 5 times greater risk of developing it yourself. With a first-degree relative, you share an average of 50% of your genes. Borderline personality disorder is a severe complex mental disorder that traditionally is more frequent in the female gender in clinical samples. Women are 75% more likely to receive it compared to men. Authors found that female patients were more likely to be misdiagnosed with BPD when both the physician and the patient were females, suggesting less acceptance of borderline-like traits and behaviours in women by women. The main results indicated that men were more likely to endorse the criteria intense and inappropriate anger and impulsivity, whereas women endorsed the criteria chronic feelings of emptiness, affective instability, and suicidality, self-harm behaviours. Bias in the diagnostic threshold was shown by inappropriate and intense anger was considered more pathological in the female sex than in the male, despite being more frequently reported in men. Ambivalence involves simultaneous movements towards and away from change as an approach avoiding conflict. It can be objective, subjective, implicit, and explicit. Service users with personality disorders often challenge clinicians because of their detached and restricted behaviours, which may be interpreted as a lack of motivation for treatment and lifestyle changes. The concepts of treatment, alliance, and countertransference have been seen as effective models in the intervention with personality disorders and ambivalence. Engagement is not one size fits all. What successful engagement may look like for one person is different for another. It depends on the context, person, place, and time. For example, with a personality disorder patient, it could be the ability to choose, to set boundaries, to stay the whole session, to play, and give eye contact. Engagement is important because it can improve staff confidence when caring for this client group, lower stigma around the diagnosis, and promote a more positive experience of care for individuals with a diagnosis of personality disorder who are in an inpatient mental health service. 6 key themes were indicated for the successful engagement of personality disorder service users. These were the right frame of mind, knowing the service user, knowing when to engage, service user input, a unified approach, and structured admissions. Mentalization-based therapy is a type of long-term psychotherapy. Mentalization is the ability to think about thinking. It helps to make sense of our thoughts, beliefs, wishes, and feelings, and to link these to our actions and behaviours. Mentalization-based treatment has been proven to be beneficial in the management of borderline personality disorder. MBT encourages an individual to focus on their mental states, affect their own behaviour, as well as the behaviour of others. Mentalization-based therapy allows them to step back from the urge and say to themselves, that's not a healthy way of thinking, and I'm only thinking this way because I'm upset. When combining art and mentalization-based therapy, the therapist monitors the levels of reflective functioning, utilizing the implicit, explicit, internal, external, self, other, and cognitive affective dimensions of mentalizing. Other therapies include CBT-PD, which takes a developmental perspective, engaging the person in producing a narrative formulation of their unique circumstances and problems. Treatment technique focused on emotional and behavioral regulation, usually in the context of interpersonal relationships. When cognitive behavioral techniques and expressive arts are combined, the therapist has the possibility through verbal modalities to explore the thinking, identify the maladaptive thoughts, and start a modelling process aimed at building more adaptive thoughts and behaviours. Artistic expression can be cathartic and provide valuable insight through personal reflection. This process is integral in helping an individual with a personality disorder to focus on personal behaviours instead of focusing on external influences that distract the individual from reflecting on personal behaviour. Art therapy confronts people in a direct way with their own patterns of feelings, thoughts, and actions. This fits the core problems of people with PD, such as managing emotions and having lower emotional awareness. To risk management, you can do things such as identify, analyse, and evaluate how the service user is using the art materials, as well as what they are drawing, observing their behaviour and mood, and how they are reacting with you in the room, ultimately deciding how these relate to their known risk factors. If risk factors are identified, service user and therapist will need to work together to consider these and draw a plan of how to manage them. Some things could be noticing for sharps, mental distress, burnout, compassion fatigue, and using things such as alarms and your MDT environment to make sure that yourself and the service user are kept safe. Therapeutic attunement refers to the nonlinear process in which therapists track the moment-to-moment changes in the somatic, emotional, and energetic rhythms of the client, themselves, and the intersubjective relationship that exists between them. The process is similar to the way an attuned parent noticing a child's distress will take steps to offer comfort. It's about giving appropriate responses. When we empathetically attune to another, we gently tune into, sense, and resonate with their experience, making it possible for us to reflect back accurately to them what we have understood, how they are feeling, that they have been listened to and heard. This video investigated the specialised area of personality disorders within inpatient adult psychiatric units using art therapy. The video aimed to inform, educate, and persuade using the theory of how a safe and effective practice can be tailored for personality disorders. For instance, when facing challenges such as risky behaviours, co-production was explored, and the benefits of this allowed the service user to feel heard and put first, as well as the function of art making building connections, resilience, and self-esteem. It focused on areas such as the risks of nonverbal interventions and the interpersonal and heightened risks of working with personality disorders, such as within areas of dissociation, engagement, and ambivalence.